Hello, I'm Ima Sagar, and we are going to talk about Glasgow Coma scale. Objective: Introduction, definition, I score, verbal score, motor score, interpretation, and summary. Introduction: The scale was established in 1974 by Graham Tasdale and Brian J. Janet, professors of neurosurgery at the University of Glasgow's Institute of Neurological Sciences at the city's Surgeon General Hospital. A patient is assessed against the criteria of the scale, and the resulting points give a patient score between 3, indicating deep unconsciousness, to 15, full consciousness. Definition: The Glasgow Coma scale is a neurological scale which aims to give a reliable way of recording the consciousness state of person. So we can see the scale and scale scoring. GCS checks three components: eye responses, which is the scale at 1 to 4, and verbal response 1 to 5, and motor response 1 to 6. And we can see the graph of the GCS scale, which depicts the eye opening, best verbal response, motor response, and the total scores. Eye response. There are 4 grades, starting with the most severe: no eye opening, eye opening in response to pain stimulus, a peripheral pain stimulus such as squeezing the lunula area of the patient's fingernails more efficient and central stimulus such as trapezius squeeze due to a grimacing effect. Eye opening to speech, not to be confused with the awakening of a sibling person. Such patients receive a score of 4 or not 3 eye openings simultaneously. Verbal response. There are 5 grades, uh, starting with the most severe: no verbal response, incomprehensive sounds, moaning but no words, inappropriate words, random or exclamatory articulated speech but no controversial exchange, speaks words but no sentence, confused. The patient responds to questions coherently, but there is some disorientation and confusion. Oriented. Patient responds coherently and appropriately to questions such as the patient's name and age, where they are and why, the year, the month, etc. Motor response. No motor response. Decelerate, posturing, accentuated by pain, extensor response, abduction of arm, internal rotation of shoulder, pronation of forearm and extension at elbow, flexion of wrist and fingers, leg extension, plantar flexion of foot. Decorative posturing accented by pain, flexure response, internal rotation of shoulder, flexion of forearm and wrist with clenched fist, leg extension, plantar flexion of foot. And so we can see the posture, which is flexure and the extensor. In flexure, we can see the problems with the cervical spinal tract or cerebral hemisphere, and we can see the extensor with problems within midbrain and or prawns. Withdrawal from pain. Absence of abnormal posturing, unable to lift hand past chin with supraorbital pain, but does pull away when nail bed is pinched. Localizes to pain. Purposeful movements towards painful stimulus. That example brings hold up beyond chin when supraorbital pressure applied. Obeys commands the patient does simple things as asked. Next is interpretation. Generally, brain injury is classified as severe, which has a GCS scale of greater than 8 to 9, and moderate, which has 8 or 9 to 12, which is controversial, and minor, which is less than 13. And for alert, it's 15, and respond to verbal stimulus is 13, respond to stimulus is 5, and unresponsive is 3. Limitation. Tracheal intubation and severe facial or eye swelling or damage make it impossible to test the verbal and eye responses. In these circumstances, The score is given as 1 with a modifier attached, example E1C, where C is the closed, or V1T, where T is the tube. Often the 1 is left out, so the scale ends EC or VT. The GCS has limited applicability to children, especially below the age of 36 months, where the verbal performances of even a healthy child would be expected to be poor. That's all.